Welcome to this month's Understanding ADHD Speaker Series event, hosted by the ADHD Empowerment Meetup Community and the nonprofit Children and Adults with ADHD, or CHAD for short, of Greater Los Angeles. I'm Suzanne Sophos, our Executive Director and today's moderator. I'm also an adult with ADHD and mom to an amazing son who also happens to have ADHD. If you're new and this is your first event with us, please let us know in the chat so we can welcome you. We invite everyone to let us know in the chat where you're joining us from today, and feel free to introduce yourself. We encourage you all to use the chat feature at any time during the meeting to share your questions and your thoughts and get to know your fellow attendees. Today's Understanding ADHD webinar is just a part of our work to educate, support, and advocate for adults and children living with ADHD. We've been hosting this speaker series for almost a decade, bringing in experts on the topic of ADHD directly to the community. We also host online peer support groups for adults with ADHD, young women with ADHD, and parents of ADHD children, as well as weekly meetups for body doubling and co-working, an ADHD 101 discussion group, and a journaling and meditation group, as well as our private Discord chat community. All of our events are facilitated by our team of volunteers, and all of our work is funded by donations. Our mission is to ensure that everyone who needs ADHD education and support can receive it, regardless of finances. So there's never a fee to attend our events. However, we are a nonprofit and our survival does depend on donations and membership fees. So if you're financially able and you find our work worthwhile, we ask you to consider making a $10 or $15 donation tonight to help support our work. We'll share the link in the chat, or you can use the Venmo QR code on the screen. I'd like to share a few meeting guidelines and recommendations just to help you get the most out of tonight's meeting. Please keep yourself muted. You're also welcome to use the chat feature at any time throughout the event. We invite you to type your questions for our speakers at any time during the event. The moderators will collect them and we'll get to as many as possible during our QA. Before we dive in, we like to start with a quick evidence-based overview about what ADHD is and how it impacts individuals. ADHD is a lifelong neurobiological condition. It impairs the brain's executive functions as well as delays social emotional development. Executive function skills, which I'll explain in more detail in just a sec, are vital for getting anything done. This leads to the hallmark challenges of ADHD: trouble self-regulating and self-managing. For people with ADHD, getting our bodies and minds to cooperate and serve up just the right amount of attention, focus, and effort for the task at hand can be extremely challenging. Studies show that if ADHD is not diagnosed and well treated, the related challenges can significantly decrease life expectancy by up to 13 years. However, studies also show that life expectancy and outcomes are drastically improved by two things: a proper diagnosis and a lifelong holistic treatment plan. ADHD impacts every area of our lives, so it makes sense that a proper treatment plan should also touch multiple areas of our lives. A holistic or whole body treatment plan includes a combination of ADHD education, skills training, medical treatment, and peer support. I want to expand a little on the brain's executive functions, which are both delayed and impaired in individuals with ADHD. These functions are what help us manage and regulate our planning, decision-making, learning, judgment, emotions, and actions. So if you're doing something, you're using your brain's executive function skills. The model for executive function that you see on the screen is based on the work of Dr. Thomas E. Brown. And there are several models out there, but this is the one that we really like to kind of show you all the different areas that executive function encompasses. So these executive functions that you see on the screen come online at different times and in different combinations, depending on what we're trying to accomplish. And having them work at the right time with the right combination and in the right amounts for the task we're trying to accomplish is a process that's impaired in those of us with ADHD. So it leads us to have trouble in the following areas. It's a list, so pay attention. It's the areas of planning, organizing, time management, task initiation, problem solving, flexibility, working memory, emotional control, impulse control, attention control, effort control, and self-monitoring. So all of those areas roll up to kind of us being able to manage ourselves. Executive function development continues until sometime between the ages of 20 and 29, at which time those of us with ADHD top out behind our neurotypical peers. Although our executive function is impaired and delayed, it can still be strengthened and developed. So you can think of those skills like a muscle. Along with medication or other treatments, receiving executive function coaching, occupational therapy, or creating systems for how you accomplish things can be key ways to strengthen your executive function skills even long after our 20s. Here's tonight's agenda. I am so pleased to welcome Dr. William Dodson and Beth Bardeen this evening to talk about ADHD and rejection-sensitive dysphoria, or RSD, from two perspectives, that of the clinician and the RSD survivor. I'm sure many of you already know Dr. Dodson thanks to his tireless work on behalf of the ADHD community. Dr. Dodson is a board-certified psychiatrist who has specialized in adults with ADHD for the last 25 years. Although Dr. Dodson is retired from his clinical practice, he's busier than ever serving the ADHD community and remains on the forefront of diagnostic and treatment reform for ADHD and rejection-sensitive dysphoria. We're also so happy to welcome Beth Bardeen, a neurodiversity advocate and the director of CHAT of Seattle. Beth is also an RSD survivor, and tonight she'll share what RSD feels like while Dr. Dodson illustrates what it looks like from the outside. Welcome to both of you. We're so glad that you're here.
Thank you guys so much for being here. I'm going to let you share your screen now so that we can get started with your presentation. And I'm going to unspotlight myself. There we go. Welcome.
Hello.
Welcome, everybody. So, Dr. Dodson, oh, am I muted? No, I'm on.
No, you're both on.
Good.
But these slides are not, there we go. Slide wasn't moving forward.
Now it's going really fast.
Oh, I was catching up with where we were.
We need, yes. So when we started working on this, I was thinking about it from the perspective of what it feels like on the inside. And I remembered a lot of times people will ask me what my first memory of learning about rejection-sensitive dysphoria. And I was sitting in my car outside of my ADHD coach's appointment, listening to a webinar with a Dr. Dodson speaking, describing this thing called rejection-sensitive dysphoria. And as he was going through the description, I just had these uncontrollable tears just like well up and start like just streaming down my face, because he was talking about something that I had never talked to anybody about. I didn't even know that it had anything to do with ADHD. And listening to somebody describe it, it made me feel more vulnerable. It made me realize that I wasn't alone. And it made me really want to figure out more. It became my new special interest. So when we think about RSD, it's that emotional pain that happens when we get triggered by rejection or criticism or, that shame that you feel when you didn't measure up to yourself or somebody else's expectations. And it's part of what I call ADHD's emotionality. And we'll go into that later. Dr. Dodson does an amazing job explaining it. It's so difficult to self-regulate without treatment. And we'll talk about the different ways, different forms of treatment. But the important thing is that it's not a matter of weakness. It's unbearable emotional impairment. And anytime I try to explain this to somebody that doesn't have it, the first thing I get is, nobody likes to be rejected. And I try to explain, and a lot of times not very effectively, it's not a behavior. This is an impairment. This is my inability or my lack of ability yet to be able to control something that is controlling me. And I relate it more like an allergic reaction, and nobody would call an allergic reaction a behavior or a lack of self-control or impulsivity. And so I try really hard to learn about the research or the medical point of view for the terminology, because I can find them triggering, because I feel like they are rejecting my experience the more I learn about it. So I see a typo in here. But anyway, Dr. Dodson's work with the FDA-approved medications has been transformative for my life and for several, other people that I've talked to. And we'll go into that. It takes a while. I got lucky. I think I went from, learning that I had ADHD to probably 2 months later learning about RSD. So I wanted to give that context and background. Let's go ahead and advance the slides, please. So there's different types of rejection. I don't think, any of this is going to be a surprise to anybody, but it's important that we kind of center on this so that as we go through the rest of the presentation, we have an idea of what we're talking about. So, personal, professional, family, partners, at school, at work, creativity, yourself. I am my own worst critic. My mom used to say that about me. She didn't need to discipline me. I took care of it because it's very hard on myself. And context is key, because sometimes same thing, the same trigger by somebody else or in a different circumstance, or if I've got enough hydration or whatever it is, it doesn't bother me. Other times it sends me over the edge. Different types: underestimated, questioned, doubted, directed, corrected, bossed. Sometimes those things can be related to the other parts of emotional dysregulation, but really what these are about is that it's suggesting that your opinion, your self-worth, your input is not valued. It's being rejected. And so you see enough people that disrespect or boss on you, or if it happens over and over again, it starts eroding your own self-respect. And it leads, of course, to not, imposter syndrome, anyone? Exclusion, isolation, all those things. It just, nobody likes it, but for us, it just piles on. Next slide. So this slide is all about helping us kind of center on what it's like, because we've got a lot of different emotional stuff going on. RSD is part of our impulsivity, and it can, sneak up on us. I have found that through my progress with RSD, that the more I learn to control or my skills, the more I see other things that I'm responding to as rejection that I wouldn't have noticed before, like my password being rejected. Things I would never have thought of that before. It felt viscerally inside, but it never got out of that. It always has a clear trigger. And the thing that it took me a while, I actually discovered before I learned I had ADHD is that you can have multiple episodes in a day. And when I was working with a therapist before being diagnosed with ADHD, she would insist that I bring my episodes and discuss them to my sessions. But this stuff was going on 24/7. I couldn't save it all up for the next week, and I was on to the next one. And yet the stuff was like imprinting on me internally. And so getting those skills to be able to pull us through to the next week is super important. Next slide. Oh, wow. You know, we all do both of these, and maybe some people might do one more than the other, depending on their makeup. But when we internalize, it's like this soul sucking, pulling in. It's like our surroundings, everything. It's like we're cut off. The connection has broken, and time will stop. You know, the fight, flight, or freeze, fawn. That's us. In a black hole. Completely disconnected, and it is the worst when we start getting reconnected and we see just how misunderstood we were. But if we're externalizing, we might actually physically respond, like a panic attack, or you know, repeat the same thing over again in different ways to see if we can maybe land what we are trying to explain, and it doesn't work. And we really feel injured. We feel injured by the person or whoever, whatever triggered it. And I know for myself that when I'm in this moment and I feel like I need to lash out, it's pretty much the same intensity of of the hurt that I felt. So and yet it can be both, just depending on the triggers. Next slide. Why do triggers trigger? Well, it depends, and context is everything. For me, triggers come from someone or something that matters. I had one marriage that it was more like I was married to a best friend, almost family member, but I didn't feel necessarily romantically attached. And in my second marriage, I did. And so when I started feeling the honeymoon being over with the second marriage, I felt RSD more intensely than I did, because there was really no honeymoon ending with the first marriage. It was more just best friendness. And so sometimes if a car honks, it might trigger you, might not another time. So what's your relationship to the person? Are they your boss? Are they your parent? Is there some sort of power dynamic between you and this person where you don't feel like you're in control? You know, the environment. Is it something that's come up repeatedly in your past? You know, what are your reserves? Have you had enough sleep? Have you had enough to eat? Were you just in stressful traffic? Did you have a bad day at work? Is there something already going on between you and the trigger that is just unresolved? Whatever it is, if we can get those who care about us to be open to these nuances and be curious about these nuances, and certainly not use them against us, then at least they can be learning with us. And sometimes that helps reduce the triggering. Next slide. What does it feel like? It's awful. Again, the more important somebody is to us emotionally, the more intense the reaction to what they've done. Doesn't matter if it's romantic or professional or, you know, a customer service agent that's not helping us get into our bank account. It feels like a rupture. I've heard other people say it's like a bottle rocket going off. And there's this connection with the other person that is just severed. And then it's like you're cut. I hear a lot of people talk about feeling, you know, free floating in space. And I can't even count the number of times I've wondered, how do I get out of this? And so a lot of times I just want to run away. But the other thing that I've learned is that it's so contextual with how or where we are on our RSD path. Like, where are we? Are we brand new? Have we just been diagnosed? Are we already in the middle of a really difficult job or a difficult home life? Like, there's not a lot we can take on at that time. But as time goes on and we start building our coping mechanisms and we get some good treatment strategies, then it makes it easier to deploy some of the stuff before an episode, because it's so difficult to do it when you're in an episode. You can't anchor yourself to anything. And I guess the most important thing that helps me is knowing that every episode will end. And if I focus on my breathing, it's that mindful, just like attention to my breathing. It brings me in, it brings me back, and it makes it easier to re-engage. But while we're in it, we live in the now anyway. We're the most mindful people ever. We're always living in the moment because it's now or not now. And so even more so in an RSD episode, we lose contact with the past and the future. Next slide. Sometimes peaceful looking. So what is it like when we're triggered? This is my dissecting an RSD episode, and thinking about every step of the way. And so I've got the trigger, and for me, seeing the trigger coming in, it's almost like I start getting that feeling right here where my breath starts to hold. But when the trigger impacts and the drop hits the surface tension pulls it in and down, and that's that disconnected feeling where it's sucking you in. And then you get your reaction, you get the other person's reaction. And then you start climbing out. For me, I got to get away. I'm going to go into the other room, down the hallway, to the conference room, out the door. I just have to get away. And once I escape, then I can start breathing and thinking and reflecting on, was this an overreaction? Was this an okay reaction? What was my part in it? What needs are unmet? And as the reflection starts kind of going into the fade, I can come back and I can start working on reconnecting and the healing. But I don't feel like the fade ever goes away. I feel like I can feel almost all of those RSD episodes all the way back to like 4 years old. They're all tattooed on my psyche. And so I don't feel like they ever really fade away, but the episode itself, for me, the trigger to escape, 20 minutes. I know other people are an hour. Super curious what other people's experience is. Would love to hear about that. Next slide. So this stuff is painful and intense, and we don't like it. And we see that other people in our lives don't like it either. And so we try really hard to avoid it. And by doing that, it affects our personality and our personality growth. And we start out very young as children learning, if we try really hard, if we overachieve, if we get it right, it'll be one less thing to be rejected. If we people please, that'll take care of some of the times when we're not quite achieving the overachievement. And the challenge with this is other people's goals become ours, and we don't even remember what ours are anymore. My goals and desires are yours. What do you want? How can I help you make my life better? And when those things fail, it just feels safer to not even try. And some of the things I've done to avoid this stuff is ridiculous. I've ended up at Mount Rainier with no picnic basket because I couldn't say I didn't get it. I could never say to the family, I didn't bring the picnic basket. And yet we got to Mount Rainier and had no food. The coping mechanisms to avoid it, it does change us. But the good news is that as you start climbing out of this, you can start working on that personality development, or not even work on it. It just kind of unfolds. And these coping skills will rescue us today, but they don't last very long. They're not sustainable. Next slide. I'm getting emotional. Weird. So this is somewhat of a repeat of the last slide, but I really wanted to talk about kind of under the hood of these things. So when we are overachieving, when we are people pleasing, they become a default mode. We don't even know we're doing it. We think that these are our superpowers. And we get to a point to where we know what people want before they do. I used to have a boss who was a VP who insisted I'd be in the meetings because he couldn't read faces, and I could. And I could let him know everything that was going on in the politics world that he couldn't see. Because I'm really good at reading the body language and the facial expressions and seeing what the alliances are. And we're also really good at figuring out mid-sentence, oh, somebody doesn't like what I'm saying, let me shift because I see a bad mood coming. And just in case it doesn't work out, our superpower is to sidestep it, to avoid the confrontation, and use our other superpowers just so we don't have to be overwhelmed or get caught or fall short. And none of this helps. We're just going to go hide. We can't do it. And we will disconnect for a period of time. Next slide. Bill said this a couple weeks ago when we were working on this. And it's one of those profound statements so well articulated that is true. If we don't master our RSD, we are just in this constant grip of reacting to what other people expect of us and what we expect of ourselves. And the really scary part is when you start working on this, you know, in your heart, you fear, and it's not really baseless because we've experienced it, that if we try to figure out what our needs are, they're not going to want to be with us anymore. That's a fear. And it's, you know, not always the case, but it's what we're afraid of. Next slide. Okay. I probably should pick up on I get really into the weeds here. It can get much better. And we'll talk about more of that later. Like I said earlier, where you are in your diagnosis is the degree to which you can manage it. The process is just different. How you deal with an episode. Somebody 5 or 6 years along, they can actually extract themselves. It's learning how to do this, how to manage it is common amongst many of us, and it can be learned. And the medications can be transformative. And then the distractions and all the different types of treatment really help us in the moment. Next slide. Off to you, Bill.
Okay. When you go out there and you want to talk to your clinician about what you've been experiencing and things like that, very often you'll, just by necessity, be seeing a clinician who has had very little, if any, training at all in ADHD. 93% of adult psychiatry residencies do not mention the term ADHD in 4 years of training. So your odds are, if you're seeing a psychiatrist, you're going to find somebody who has absolutely no idea what you're going through. People with, and they don't want to know. People with ADHD, though, when they hear the term RSD and they hear what it means, identify with it both immediately and intensely. There are, for instance, more responses on Reddit, that great scientific journal, to the subject of RSD than to any other posting they've ever had in their existence. It touches people very deeply. But RSD usually, until a person self-identifies with it, is usually hidden because it's too painful. People don't want other people to know that they can't control their emotions. They feel childish, they feel vulnerable, they feel very, very ashamed. So your clinician needs to be open to learning about it, or preferable still, already know about it before you get there. And that's why organizations like CHAD and the group that meets on Sundays are invaluable, because you know who's good in the LA Basin and who is not. And you know by bitter experience. So it's very important that you be treated by somebody who's open, non-judgmental, curious, and who wants to improve the therapeutic relationship. Because I can tell you, if you are greeted with doubt, with being made fun of, that's usually the end of that particular therapy. It's very hard to go back and be open with someone who has done that to you. Mood dysregulation in ADHD is a very big topic right now, mostly out of Europe, where in 2019, they added mood dysregulation, emotional dysregulation, as a fourth core symptom of ADHD. In other words, you would not have ADHD if you didn't have mood discontrol. People with ADHD nervous systems lead intense, passionate, emotional lives. Their highs are high, their lows are much lower. And that's usually what gets them misdiagnosed as having mixed anxiety and depression. And RSD is virtually always triggered by events and perceptions. But the moods are, what the technical term is congruent. In other words, the mood matches your perception of what the trigger was. The shift happens instantaneously. You can be having a great day and you get hit with an episode, and before you can say, holy shit, you're in the depths of an RSD episode. There's no way to prepare for it in advance unless you see it coming. Luckily, people usually get over these episodes quickly, although quickly is a relative term. It seems like it takes forever. And for some people, it can be sustained for days. But it is not sustained for weeks, like mood disorders. By definition, a depression has to last uninterrupted for at least 2 weeks. So the thing all this is there to remind us of is that RSD episodes are not mood disorders. A mood disorder, by definition, is untriggered, comes out of the blue, very gradually, days to weeks of onset. It sticks around for at least 2 weeks. And then there's a very gradual return to normative functioning. So that if you put mood disorders and RSD together, they share nothing in common. And yet, 9 times out of 10, when you go in to see a mental health professional, you're going to be misdiagnosed as having mixed depression and anxiety. We also have 3 separate terms floating around out there that many people use interchangeably, and that's too bad because they're actually 3 totally different things with totally different origins and, more importantly, totally different treatments. The one that comes from Europe is emotional dysregulation. And what that means is we get blindsided by our own emotions. They pop out impulsively, and it really does depend on who you ask what the definition of emotional dysregulation is. Russell Barkley, of course, sees it in terms of executive function deficits, where you don't have the abilities, the skills to control your mood. Fred Reimer may not be a name that's familiar to everybody, but he was one of the 2 people that originally defined the ADHD syndrome, the other person being Dr. Paul Winder. And he is still out there researching and doing marvelous work in his 90s. There are rapid swings, and it's an emotional overreaction to something. It doesn't just come out of the blue for no reason at all. And according to Reimer, it is the largest contributor to an impairment in people with ADHD. And that finding has been repeated many, many times, even though emotions are not part of the diagnostic criteria. They were intentionally disregarded. Reimer has also shown that these emotional outbursts are not the manifestation of other coexisting conditions. And he also has shown very conclusively that these episodes of emotional dysregulation respond beautifully. In fact, for 2 out of 3 people, essentially cured, it's no longer there, to stimulant medications. Steve Frone, who's probably the best thought leader in the field right now, tends to see the anger that comes out in emotional dysregulation and loss of emotional control, whether it's irritability, rages, fits of temper, things like that. None of the people who are writing about it, though, ever look at it from just a practical point of view of what it's like to have these yourself. For one thing, everybody has lost control of their emotions. I've gotten mad and wanted to kick the dog. I've lost my temper in my life. So it's something that, again, is a universal experience. Emotional dysregulation or loss of control of emotions is found in more than 40 other DSM conditions. So it is not unique to ADHD. There's another term out there called rejection sensitivity, unfortunately. It's an emotional component, but not specific to ADHD. Again, rejection sensitivity is based on what has happened to us. It's not like most of the diagnoses in the DSM, which are genetic, neurologic. It runs in families. Just as ADHD runs in families, depression runs in families, schizophrenia runs in families because it's genetically and neurologically based. And so this type of sensitivity to rejection, being put down, etc., comes from what happens to us, traumatic events that happen to us. So there's nothing in this world that cannot be made worse by a hostile, toxic childhood. And having multiple rejections can have a profound effect upon self-esteem, self-confidence, and self-worth. There's an excellent article by Dr. Michael Jelinek at Harvard that estimated that by the time a child with ADHD got to be 10 years of age, he or she has heard 20,000 additional negative or corrective messages at school alone. It's not counting coaches and parents and places like that. 20,000 additional messages that you are not what I want. There are also several studies that show that by the time a child with ADHD gets to the third grade, 70% of them do not have a best friend, usually have no friends at all. So people with ADHD are very well acquainted with real life rejections. This excessive rejection tends to lead to a lifelong misinterpretation of neutral events as being rejected. Sometimes they're able later on to go back and say, well, that really wasn't, I wasn't rejected, I was disappointed. But that's usually what happens. It hurts so badly that people with ADHD are vigilant for it, and at the very first thing that looks like rejection, they have a full response. Because rejection sensitivity comes from experiences that happen to us, they have virtually no response to any medications. So PTSD being the classic example, or traumatic head injuries or things like that, things that happen to us, really don't respond almost at all to medications. Rejection sensitive dysphoria, unfortunately, it's a terrible name, but we're stuck with it. That's the name they gave it back in the 60s when they first started researching it. It is my belief, my experience, that it is an emotional component that I personally think is specific to ADHD and ADHD alone. That remains to be proved, but that has been my experience. An interested clinician, an experienced clinician, will ask the definition of right from the textbook of what rejection sensitive dysphoria is for your entire life. Have you always been much more sensitive than anybody else you know to rejection, teasing, criticism, or your own perception that you've failed or fallen short and you're criticizing yourself? In my personal practice, well over 3,000 patients, 98% of them gave a strong yes to that question. 33%, right at 1/3, said it was by far the most impairing aspect of their adult ADHD. They had found ways around their academic and work performance, but they had not found any way to protect themselves from rejection. There are 12 core features of RSD, just as the first two, emotional dysregulation and rejection sensitivity, are found in multiple different conditions, and nobody can quite define them. Rejection sensitivity has 12 very specific, almost inflexible signs and symptoms. There's a limited number of triggers: rejection, teasing, criticism, or self-rejection. Many people refer to themselves as their own worst enemy. The mood shifts are always triggered. They don't just come out of the blue. They don't come gradually. Others may not notice what the trigger was, but the person with ADHD can tell you every time what the trigger was. Our perceptions are our reality. Again, what we perceive to be true is true to us. Anticipated rejection is often misunderstood and mislabeled as anxiety. Anxiety, the definition of it is a baseless, apprehensive fear that for no reason at all, you anticipate that something awful is just about to happen. That's what anxiety is. People with ADHD know exactly what they fear and why. The moods in RSD match the experience, what the trigger was, and there's no time to stop a mood change in RSD. You go from 0 to 100 in the twinkling of an eye. That is why if you are going to modify RSD, you have to do it in advance. Prevention, prevention, prevention. Those are the 3 different treatments of RSD. Once it's started, you just got to ride it out and go until it runs out. So knowing your common triggers, knowing what, if you get tired, if you get hungry, if you get thirsty, knowing what those are, help you prepare yourself and be at your strongest. And this is a lifelong self-care skill. And work with those who care about you. One of the worst things about ADHD type rejection sensitivity dysphoria is feeling so very alone, especially during the episodes. We've already done that one. Next feature is that people with ADHD cannot find words to describe what it feels like. You may have noticed tonight that people can talk about its intensity. It's awful, it's terrible, it's catastrophic, but not actually describe what the pain is like. Right, as close as they can get to it is that it's a type of wound, because it not only is emotionally painful, it is physically painful. You'll see people punch over like they've just been punched in the chest, slammed. It's a not only emotional but physical pain. So the take-home messages are really mostly about the thing that is most confusing, and that's just the plain old rejection sensitivity that comes from having just a really crummy life full of criticism and rejection. Rejection sensitivity without the dysphoria still has profound effects upon self-esteem and self-confidence. And rejection sensitivity comes from experience and therefore has very little response to medication like the other 2 do. Why is it missed? Well, first of all, so about the last 10 years ago, nobody talked about it. The patients didn't want to talk about it. The patients didn't want anybody to know this terrible vulnerability they had that made them so ashamed. A clinician now would have to read the lay literature, because to this day, rejection sensitivity dysphoria does not exist in the scientific literature except as the cardinal symptom of what's called atypical or non-typical depression. And the reason it wasn't typical depression is that it had no features whatsoever of a mood disorder. What they were looking at then and now was the rejection sensitivity dysphoria of ADHD. So let's try and lay it out, spread it out, and look at how the rejection sensitivity can be misunderstood unless the doctor slows down and finds out what's behind your experience. Depression we've been through, again, it's a very gradual onset, sticks around for a while, gradual offset, and no trigger. Anxiety, again, physical symptoms of trembling, shaking, sweating, and sometimes an extreme irrational avoidance of what they think triggers it, and that's where phobias come from. Borderline, because the trigger for these emotional explosions are usually other human beings, some interaction with another person. Borderline personality disorder can be mistaken for rejection sensitivity. And of course, there's no reason in the world why you can't have won the negative genetic lottery and have both. Somewhere between 35 and 40% of people who carry a diagnosis of borderline personality disorder will also have a diagnosis of ADHD. So you can have both, and both will require treatment. Bipolar, again, is just another mood disorder. And even though the moods swing, the onset of the mood is very gradual, very slow, for no reason at all. It takes weeks to months for these episodes to come on, and weeks and months for them to leave. So once again, just trying to emphasize this, because you're going to be pushed into that closet, that little cubby hole, unless you're able to tell the doctor why this is not a mood disorder. You do not have depression or anxiety. So the take-home messages about emotionality in ADHD. If you have ADHD, it's not that you have one or the other. You've got all three. Again, you've won the negative genetic lottery. You have the same emotional dysfunction that everybody has, only with a vengeance. Again, because your life is lived intensely and passionately, your emotions will from time to time get out of your own control, causing a profound sense of shame over that sense of loss of control and feeling childish. Luckily, 66% of people with ADHD report that their emotional dysregulation goes away entirely when they take their stimulant medications. Rejection sensitivity, again, comes from life experiences, and it's a deep and profound sense of shame over their loss of control, their flashbacks, and things like that. And because it is something that happens to us, it's not something we're born with. Usually, rejection sensitivity and traumatic events do not respond to medication. Instead, they respond to somatic therapies like EMDR and to cognitive behavioral therapy, dialectical behavioral therapy, and things like that. And they respond extremely well to that. But it's a long, long road. Rejection and sensitivity, again, it is my opinion that it is something specific to ADHD. Other people don't have this very specific syndrome. Again, it has a profound effect upon the development of our own personalities. But again, luckily, about 2/3, somewhere in there, will get an almost complete relief of symptoms from old blood pressure medications called alpha-2 agonists, which we will now talk about. The alpha-2A agonists, there are only two of them available in the United States, guanfacine and clonidine, which is still one more than is available in any other country. They were on the market in the early 1980s as blood pressure medications, and luckily for us, they didn't work very well, and so were almost immediately replaced. And people went out looking for other things that these medications could do. For instance, they are the treatment of choice for vocal and motor tics. They can block the experience of opiate withdrawal at the brainstem so that you can suddenly stop opiates and not know it. When somebody can't get their opiates, all of a sudden alpha agonists become very popular. The benefits, each time you change the dose, take about 5 days to develop. So the fastest we can change the dose is every 5th day. Again, just to remind you, the alpha agonist cannot be used in response to an episode, because it's going to take you 2 weeks to get up to a therapeutic blood level. Consequently, they must be taken, usually at bedtime all at once, but every day. You miss 2 or 3 days in a row, and you're back to having to start over retitrating your medication from start. There is a very big group of people who respond at 0.3 milligram of clonidine and 3 milligrams of guanfacine. 80% of people who get that robust response, that will be their ideal dose. But that also means that 20% of people who are going to get a great response will get at doses that are either lower or higher than that 3 tablets. The alpha agonists work beautifully for a lot of things other than rejection sensitivity dysphoria. It also gives you a sense of peace. The standard question is, look back over your entire life. Can you remember a period of time longer than 5 minutes, and not back in your wild and woolly youth, in which you've been both mentally and physically at peace? Stop and think about that one yourself. Most people say, are you kidding? No, my mind is constantly going on something. I'm never at peace. These medications also help you cut down on the number of thoughts. The question here is, how many completely separate lines of thought do you have going on in your head at any given time? Most people will say at least 3. And this is not, they're not jumping from one to the other. These are 3 totally separate thoughts. And as you can imagine, when you're trying to shut down your brain and body so that you can sleep at night, it's very, very difficult if you have 3 lines of thought yelling at you, trying to get your attention. About 80% of adults with ADHD spend 2 hours or more trying to shut off their brain so they can settle down and go to sleep. The nice thing about the alpha agonists is that they shut down the hyperactivity, the impulsivity, and allow you to sleep. They don't put you to sleep. There's an axiom in medicine that goes, it's always better to treat the cause of the symptom rather than merely suppress the symptom. And that's what these medications are doing here. There's also another important thing, and that is that just about everybody with ADHD will try at some point in their lives to self-medicate their ADHD with a whole variety of things. And this self-medicating of chronic insomnia is how the majority of my patients end up being daily users of marijuana, daily users of alcohol, sleeping pills, and the like. When if they'd just been taking an alpha agonist that allowed them to sleep normally, that wouldn't have happened. This is a great preventative of a lot of drug abuse. These medications, after the first week, the daytime sedation goes away, and the nighttime sedation. You're not going to bed or to sleep because you're sedated. You're going to sleep because your brain and body are at peace. Of course, everything has side effects. The alpha agonists only have 4. Anytime that you're turning down the volume on your adrenaline system, you're going to be slowed down and feel a bit sedated. Usually it is very minor. I've only had one person ever who was not able to get up the next day and go to school or work. The sedation usually, if it is there, and it's only there for about 20% of people, the body gets tolerant to it in a week. Dry mouth can be a problem because the stimulants have as a major side effect dry mouth, and you add another medication that causes dry mouth, and it can be a real problem until you become tolerant. So carry a bottle of water and try xylitol melts, under the brand of Zymelts, to keep your mouth moist until such time as you can get tolerant. Some people get a mild headache, usually because, believe it or not, even with as dry as your mouth is, they're not hydrating adequately. But usually this can go away with a big glass of water and an aspirin. Finally, you can get, and you got to love these terrible terms, orthostatic hypotension, which is a fancified way of saying a universal experience. Everybody listening to me right now has had this. When we stand up suddenly and without warning, and we get a little dizzy, vision goes a little gray, get kind of a head rush. That's because the blood is flowing to our feet. This can become more frequent on these medications until the person becomes tolerant. So, how do you start on the medications? For some reason, I don't know why, but it's a very hard concept to get across, is that you only take one medication at a time. A week does not go by that I don't get an email or something like that about taking both medications. Don't do that. So you start off, do you have rejection sensitivity dysphoria or hyperarousal? Try one of the alpha agonists. They work equally well. One is not better than another. If you get up to an adequate dosage, 30% of people will have a life-changing level of benefits. It's truly life-changing. So if you're at a dose of 3 tablets and you're going, I don't see much, it's not working. You'll know it when these medications work. So if that happens, you stop that medication. There's no reason to take a medication that's not working, and you try the other alpha agonist you didn't try first. And again, you titrate it up over 2 weeks. And again, another 30%, but it's a different 30%, will have a very strong life-changing response to these medications. So when you put them together, that's about a 60% life-changing, robust response, which is about as good as any other psychiatric medication. So we're back to that. I surprised you, didn't I? Your sound's not on.
Yep. I've been hanging out in the chat. Hey, I'm just going to leave that one.
I can do them.
There we go. Sorry. Enjoying. All right. So Bill's talked and outlined how do you recognize it clinically, how to help your doctor help you, and how it gets confused and how not to confuse it with the other ones. One of the things that we say is, don't take this as medical advice. This is education only. Go seek help from your ADHD specialist team. But what does that mean? Because sometimes it can be hard to find a specialist. It can be hard to know of all the things that you see out there, what is going to work and which ones do you try and which ones do you lean into. And it's, the one thing that I've learned from Dr. Dodson is listen to your body, because that tells you, don't listen to the part of your body that says, I don't want to do this. That task initiation thing, that's the wrong part to listen to. But the part that you listen to is, how do these things make you feel when you try them? When I'm throwing a lot of spaghetti at the wall for all the different therapies and support groups and, medications, only my body knows what's going to work. But it's up to me to figure that out. So probably the first step, and one of the things I like to do, is be that concierge when people show up at the ADHD hotel for their ADHD vacation, is to get them on the right path. If you start with your local support groups, CHAD, ADA, I think Attitude Magazine has some, Meetup, you'll find a lot. Just at Facebook has plenty. Just getting into a point to where you realize that what you're going through isn't unusual, that there are others who can articulate what you're going through. There are directories out there. CHAD has a directory, ADA has a directory, just about everybody does. Psychology Today has a great directory. You can slice and dice according to the type of therapy that you want, what location, things that are important to you, if, gender, LGBT, whatever you need in your therapy, you can find in these directories. Your insurance company is also a good place to start, because it's always great if you can find a provider that takes insurance, and specifically your insurance. Sometimes you can submit a receipt to your insurance company for an out-of-network reimbursement. And instead of asking your family doctor if you have ADHD, or if you do, can you have some ADHD meds, or trying to educate your family doctor, ask them for a referral to a specialist within their network. You will likely get to an ADHD specialist that's knows more than they do, but they still might not know everything that Dr. Dodson's talked about tonight, but they should be curious and interested because they're an ADHD specialist. And if you're at an employer that's, 500 or more employees, they usually have affinity groups for very similar to meetup groups, but they support these affinity groups, and those are always a good place because you can go and be part of them, like in your Slack channel or Microsoft Teams channel during work when you need to reach out to somebody. Next slide. Okay, so I touched on this a little bit. General practitioners, family MDs, primary care MDs, and general psychiatrists. So I got lucky. I started with an ADHD coach who is one of the early adopters of Dr. Dodson's work. And so that influenced and put me, kind of leapfrogged me on a great path. But I was so excited about this great path when I went in for my annual exam with my primary care provider, who I'd been working with for 20 years. She is an ADHD denier. She suggested that I might be seeking drugs. She's known me for 20 years, and she's suggesting that I am seeking drugs. I told her I didn't need drugs from her, and she said, regardless, I won't work with you on this. And if you continue to take these drugs, I cannot be your doctor. And I'm like, I'm so glad you brought that up. And that was hard. And I didn't believe it. But I've read a lot in the media about medical gaslighting. And it's not because they're bad people. It's just because they don't know. So your general practitioner should refer you to a specialist, because unless they're an unusual GP that knows ADHD along with diabetes and heart disease in their 15 minutes with you, they should know who in their network can help you. If they encounter you, they will think that you have a mood disorder, because that is what they have gotten training on. Now, an ADHD specialist, they've had specific medical training on it. They are skilled in an evaluation and diagnosis, and they aren't going to do it in 15 minutes. It's going to be hours and sessions. And you will come out of there feeling better because a lot of the uncertainty has been answered. They're familiar with the different emotionalities of ADHD that Dr. Dodson outlined. And they're familiar with the ADHD medication protocols, maybe not to the degree that Dr. Dodson has, I guess, pioneered and made, super effective. Anyway, they may not be familiar with the alpha 2 agonists. A lot of them think that they're heart meds. I had to point out to my new insurance company yesterday that indeed the FDA has approved guanfacine for use with ADHD in 2010. They didn't know it. So, okay, I've already covered that. Next slide, please. Ha ha ha. This is what I faced when I went to go see my general practitioner. And I thought it was just me, but if you guys, I'm not looking at the chat right now, but if you've talked to your GP or your family doctor and you got something like this, please put it in the chat. I'd love to hear about it. It's sometimes it's just good to know that this is just part of their reality. Next slide. When you talk to, so when somebody tells me that with Seattle Chad, I get providers emailing me because they want to get connected to the local chapter. And when they say that they are an ADHD provider, I start asking them these questions. And I got these questions somewhat edited and paraphrased to fit on a slide from Dr. Dodson's Attitude Magazine podcast number 114. And this has been so effective in either not shutting down, but I can tell quickly whether or not they're either going to entertain this conversation or if they're fascinated by this conversation. But nobody should be, no specialist, no ADHD specialist should be frustrated by this conversation. Next slide. And you'll get this in the slides. Right. So what does work best for you? So if you're one of the folks, Dr. Dodson's talked about the negative genetic lottery, but if you are lucky and you're one of the 60%, guanfacine or clonidine can help you rise up to move beyond just surviving. And following his protocol on trying one, stopping it, trying the other, listen to your body, that is the best way to get there. So you got your medical and your health professionals, communities and social relationships. That is kind of the ecosystem that you want to spend your time in so that you can learn about the column on your left and you can learn about the column on your right. So the self-work is a lot. If you're already living in ADHD overwhelm, adding one more thing to learn is a lot. Sometimes you have to sneak away from fulfilling all your loved ones and your professional ones' commitments to just get yourself into some self-help work. Get your sleep, choose one. I chose sleep. 4 years ago, I chose sleep. It took me a while and I got it. Then I chose my diet. Took me a while and then I got it. Now I'm working on my fitness. You have to become a detective because as much as these providers should and often do care about you, they've got so many people and you have to become your own expert on what's going on inside your body. Use counselors and therapists for the triggering stuff, kind of like who you are today and in past. Work with an ADHD coach like an athlete does because they will work with you for who you are today to who you want to be. And along with everything else, and it's sometimes really hard with as busy as our minds are, but just learning how to do simple breath work or simple meditation like the Headspace app. Just go very basic, and these can help you. Focusing on your breath can help you through the episodes. Next slide. This is a summary slide, but I always like to have a checklist. So seek out an ADHD specialist for diagnosis and medication management. Check with your Seattle Chad, your local Chad group, your Facebook group, your meetup groups for recommendations on this. The most important thing that I could say is to resist the dangerous shortcut of asking your GP for stimulants. I know so many people who are so busy that they just want that 15-minute appointment and that stimulant prescription, not because they're seeking drugs, but because they think that's the answer. And they don't know how to find the most effective drug of the over 40 drugs out there and which dose and what time. And then they stop it because it doesn't feel good and it doesn't work. And their life goes back to the way it was. All your providers need to know what you're doing. And if they don't want to hear about it, they shouldn't be your provider. That's my opinion. Oh man, I learned this the hard way. Choose family and couples therapists that are familiar with ADHD, because if they don't have it or they don't understand it, you will spend most of the session explaining why we are the way they are. And you will be the wrong person in the room. Work with coach to grow, what you want to be, specific groups. Tracking your episodes, I started doing that because I needed to know where I was so that I had an idea that it was going to end. And I can breathe through it, but if I don't know where I am in the episode phase, I get lost in it. And it's hard. It just makes it harder for me. Identify your triggers, work with the people around you to come up with ways to disarm them, usually distractions, music, humor. I had a stuffed animal skunk that had a whoopee cushion in it, and that was so effective at stopping the episode, because you cannot have a belly laugh if you cannot be in your episode and have a belly laugh at the same time. Track your treatments, be the detective, and kind of be prepared for your well-meaning loved ones who just don't understand. Next slide. So these are the take-home messages that we had up front. Bill, you want to go through yours?
Well, first of all, rejection sensitive dysphoria is very real, just as rejection sensitivity is, and emotional dysregulation. You're going to have to deal with all three of them. Most physicians have not heard of any of them. And so finding somebody who's keeping up, who is sophisticated, if you will, about the subtleties of ADHD is really quite a task, but it is really worth the effort. And 60% of those who have RSD episodes can get that, what people call an emotional armor from these medications if they take the medications. These are not medications you can start and stop. It just doesn't work that way. So, Beth?
My perspective might sound a little bit like I have a chip on my shoulder. There's a reason for that. I do. Because not only have I been through it myself, but I have listened to hundreds of people who've been through it too. And that's why I want to help people be prepared to have that discussion with your doctor, and be prepared when they reject it, to see whether or not they're open to having the discussion. Others, even those that care about us, from siblings to partners, parents, coworkers, bosses, they don't mean to, but they will gaslight you, because nobody likes rejection. It's no different than saying, have you tried using a calendar before, or a to-do list, right? This stuff they don't understand the impairment of it. And the thing is that we've spent a lifetime hearing it, and it doesn't make sense to us either. And so we start gaslighting ourselves. Most importantly, it's the words kind of fall flat to me, but to educate yourself so that you can get the support you need, so that you know it's not just the support that you need, but it's the support that you deserve, and that will help. Next slide. I think we're done. Yes?
We're done.
Yeah, I think we're done. Yeah.
Awesome. Thank you
Huzzah.
guys so much. That was we talk about this so much during our Sunday night meetings. It comes up so often that this is so much information. My brain is just soaking it all in. And we got so many good comments and questions. I have a favor to ask. I know we were supposed to end at 7:30. Would it be okay if we stay a little bit past that to answer a couple questions?
I'll stick along as long as anybody else is here.
Awesome.
Same.
All right. So let's see. I am going to start. Our first question is from Jeremy, and she asks, what are some things that I can do to stop the spiral when I feel rejection? So in the moment.
Well, that was one of the things I tried to emphasize, is that once an episode has started, it's really hard to pull out. Prevention. That you have to learn what your triggers are. You have to learn when you're not at your best. You're tired, you're irritable, it's the week before your period, whatever it is that weakens you. Be prepared so that when you're at risk and you see it coming, you can do something about it. Once you're in, usually RSD episodes have to run their course, in my experience.
Yeah. I've had some, it was a rocky road at first with my partner and my coworkers, but I found safe people and safe ways. Like sometimes when somebody tries to help, it almost makes it worse. It feels patronizing. But if they are curious, and usually this is a partner in your life, then they may not understand what's going on, but if you work together, you can come up with not really safe words, but ways to help them not inflame it or fan the flames. Just pile onto the triggers. And then the distractions, you have to actually be so, it's really difficult, but if they turn on some music that usually lights you up and it's really powerful, it can help soften things. It's tough.
Thanks. Thank you both. So this was an interesting question from Benny. Are RSD and social anxiety disorder connected, or are there clear differences in those two things?
On the surface, they look exactly the same. Benny is very perceptive. For those who may have never heard of social anxiety disorder, it is one of those anxiety disorders in which there is an intense anticipatory fear that if you go into a certain social setting, a meeting, a bar, a dance, or something like that, that people are going to judge you harshly, that they're going to be scrutinizing you, just waiting for you to mess up, and then they'll jump you and criticize you. So it's an anticipatory anxiety and fear about what might happen. Rejection sensitivity dysphoria is you're sort of bopping down the sidewalk and there's a trigger and boom, you are in an episode. So one is anticipatory fear of criticism. One is a post-event response to the perception of criticism. But both of them can be devastating to people's social lives. With people with both, not at the same time. I've had many patients who have never been on a date, who have never gone to apply for a job because just the imagination of being rejected and turned down was so painful they didn't want any part of it. No, thank you. I'll just sit over here in the corner. So it can be absolutely devastating to people's lives. And the problem is that the disorder itself prevents you from seeking help. It's one of God's jokes in bad taste.
Mm-hmm. Good answer. Anything to add, Beth? Or
no, I mean, my son doesn't have ADHD, but he has social anxiety disorder. And, you know, we had the conversation about, well, you just need to go in and get a therapist. And then my therapist said, you haven't found it ironic that if you've got a fear of social anxiety rejection, that you're asking him to go in? Number one, go find somebody. Number two, go in and tell them all you're vulnerable, right? I mean, it is kind of this, like Bill said, it's a twisted sense of humor in the fates.
yeah.
But again, just to add a little hope to this, social anxiety disorder is one of the more treatable anxiety disorders of all of them. There are several medications that have 80-90% remission rates.
Oh, cool.
So there's a lot of hope if you can overcome the tremendous threatening fear that is the disorder.
Yeah.
That's cool.
Thank you. So this is a question about children, and it's interesting. We have actually two questions related to children. So the first one is there any groundwork that we can lay with young children to help them develop skills early, either for dealing with RSD or maybe in hopes that it won't be as severe or as impactful as it might be for adults that have it now?
The same things work in children that work in adults. Cognitive behavioral works wonderfully in children. It's hard to find any literature on sub 3 years old, but it works well for kids, just the way dialectical behavioral therapy works, EMDR works, and of course the clonidine is FDA approved down to age 3. So, in fact, its biggest use is among children, not adults.
Mm-hmm. That's the one.
So there are a lot of things that can be done. Just because the child is young doesn't mean that, well, you have to wait and suffer some more before we're actually going to do something. There's lots of things that can be done.
Great, thank you. That's very hopeful. The other question I think is interesting. So it's more along the lines of looking at your clinical populations, and is there any difference is this more prevalent in adults that have late diagnosis, or what do we see the same prevalence of it in children that are diagnosed with ADHD now that maybe have less shame about their diagnosis and better coping skills? Are there any differences in those populations?
We don't know.
Okay. We need more money for more research, right?
Gimme.
Exactly. Okay, let's see. Someone was asking, we talked a lot about the medications that work. Are there ways or things that you can point to? We also talked about how a lot of doctors are not really well versed in first ADHD, then RSD medication. So are there some places that we can point those doctors that we like and want to continue to work with that maybe are falling short in those areas to kind of guide them in these protocols, or are they too new?
Well, this is a shameful promotion here. When I'm not doing presentations like this, I'm preparing a book to be published called Successfully Treating ADHD, because there is no such book. If somebody came in and said, a doctor says, look, I really want to get hot with ADHD, 1 in every 10 patients has it. That means that in a typical day, I'll see 3 people who have ADHD and I won't know what to do with them. Where should I go? There isn't a place.
Yeah.
So that book should be out after the first of the year. Successfully Treating ADHD. I'm writing it with a neurologist from Oxford University, but it's very accessible to the average person. For doctors who just want the instructions about how to fine-tune medications and stuff like that, they can email me and I will send them a disc or something like that. It has every form I have ever developed in my 45 years of practice. I would be happy to share that with them. So if you want to pass it on to your doctor or have a pen, it's real tough. My email is Bill Dodson with 2 D's 19 @gmail. There were 18 other Bill Dodsons who got there ahead of me.
That's so generous of you. Thank you so much.
I try and help anybody that wants to learn.
That's so generous of you. Thank you so much. The next question, probably not enough research on this either yet, but someone was asking, if you can't take medication, are there any specific foods or diets that work, or things like neurofeedback?
Okay, let's handle those two. Foods have been studied out the wazoo. The federal government did a huge study, 60 double-blind controlled studies. I mean, really good gold standard studies on the effect of medication on ADHD. And what they found was all 60 of them found that what we eat has no effect. Doesn't cause ADHD, doesn't make it better, doesn't make it worse. What we eat has no effect on ADHD. Now, somebody who's trying to sell you something, it's the bee's knees. But there is no evidence ever that what we eat has an effect. Neurofeedback retraining, likewise, has been studied many times over the last 40 years, and what they have found is no benefit at all. None. Zip mucus nada.
Thank you. All right, this last question does not have to do with RSD, but you are so well known for the ICNU framework that our question is, could you briefly explain the ICNU framework and what are some practical ways for those of us with ADHD to use it to navigate challenges like demand avoidance and difficulty with task initiation?
Part of the problem with the field of ADHD is that we have been asking the wrong questions for the last 50 years. So I would like to pose a question to the people who have stuck around. Look back over your entire life, dredge up all the memories you can. If you have been able to get engaged and stay engaged with literally any task of your life, have you ever found anything you could not do? So pause, think about that. Most people, we're talking here in the high 90s, 90%, will say, oh no, if I can get started, if I can get engaged and stay engaged, I can do anything. That, the term that's coming up in the literature very infrequently is referred to as people with ADHD being omnipotential. They quite literally can do anything. And that's the reason for that people with ADHD struggle, is that all of the therapies thus far have viewed people with ADHD as being neurotypical people who are damaged, broken, deficit. That's what executive function deficit is all about. They see people with ADHD as being inadequate people. But when you answer that question, I can do anything if the situation is right. It's the situation that matters. And there are five situations in which people with ADHD can get in the zone, is the way it's said here in Denver. It's get in the groove in California, get in the flow on the East Coast, but it's all the same thing, where you can get engaged, stay engaged, get access to your abilities, do remarkable, creative work in a very short period of time. The big one is, and I'll do it in the order that people there seem to know, the big one is interest, called an interest-based nervous system. Look back over your life. If you're interested in what you're doing, it came easily. It was easy to start. It was fun. You had a great mood, great energy, and you were able to stick with it all the way to the payoff. Second one is challenge or competition. If you're doing something and somebody says, you can't do that. If your response is, oh, yeah, whatever it was, you're going to have that thing mastered today because you took a challenge.
Yeah.
Third one is novelty. Unfortunately, novelty by definition doesn't last, but during periods of doing something totally new and different. In fact, this is one of our biggest distractions. The old joke about ADHD should have been called ADOS. Attention deficit, ooh, shiny. It's the novelty that catches our attention and pulls us away from our task. But sometimes novelty helps us engage. Fourth one is urgency. Right at the do or die deadline, we can usually get engaged and turn out a huge amount of high quality work in a very short period of time. Once we've accomplished it, it's gone and we're back to being ADHD. Fourth one, key, we use the word passion. What is it about your life that you care about deeply, passionately? It gives your life meaning and purpose. Now, a lot of people say, well, isn't that important? Yeah, it's sort of important. But what makes it work is the investment of your emotions. That's what makes it something that helps you get engaged, sometimes perfectly. That's what hyper-focus is. Sometimes we're off in la la land, and sometimes that engagement with what we're doing is what we and what we're doing are one. Somebody can walk into the room, call our name, and we wouldn't notice. So it's interest, challenge, novelty, urgency, passion. How do you use that? Well, if you look at why so many of the therapies up till now have failed, is they made these huge long lists of things that people with ADHD struggled with and then insisted that they do them. Again, you just got to wonder about these people. And of course, it hasn't worked in the slightest. So what we do is we play through somebody's strengths. We have people carry around with them a pad of paper, and it says you're coming out of the zone that you recognize you were in the zone. When you're in the zone, you don't really notice you and what you're doing or why. But when you come out and you go, wow, I just got a half day's work done in about 45 minutes. Stop right then and there and write yourself a note. How'd you do it? How did you become superhuman? How did you get in a hyper-focus? Was it because you were interested? In what in particular did you find fascinating? Was it because you were challenged or competitive, and what brought out that competitive streak? And so on. Do not trick yourself into saying, I'll write that down when I get home. In the history of the world, that has never once happened. Stop right where you are. I don't care what, pull the car to the side of the road and write it down, because you'll forget it otherwise. So within a month, you'll have 20 or 30 of these techniques that you know work for you, that when you're facing a task that may be very important, may get a great reward for it, but it's so boring that you can't get started on it. You can pull out your list of things that you know work for you and say, okay, number 26 worked for me last time. I'm going to use 26. I'm going to get engaged, get access to my abilities, knock this out, go have fun. And so everybody has to write their own owner's manual. What really goes wrong for people with ADHD is that life gives them the wrong owner's manual for their nervous system back in preschool. We teach people how to be great neurotypical dull people. And we don't teach them a damn thing about how to be an ADHD star. Because people with ADHD are remarkably gifted. Average IQ is 123. That's all the IQ necessary to do anything you want and are interested in. People with ADHD are world-class problem solvers because they see the world in a totally different way. They are incredibly loyal friends. They're very affable people. They know all the latest jokes. They love nothing better than to get together and have a good time. So if you could imagine, and one more, when you do hook into something, they have what Paul Winter referred to as relentless determination. Mm-hmm. And all of you have had periods of your life where you just could not stop. So if you can imagine just going to the shelf and pulling off qualities that assure success in life, ones that I would want for myself and for my children, is I'd want them to be very bright. I want them to be very creative about how they use that intelligence. I want them to be very well-liked, affable. That people are happy they just walked into the room rather than otherwise, and we all know people who are otherwise. And I want them to be hardworking and diligent. So if you can get the ADHD out of somebody's way, stand back. They'll handle the rest.
Dr. Dodson.
So
sorry. Well, I saw
a
question in the chat earlier, and it's a question that comes to my mind a lot. Like when you said relentless determination, that just resonates with me a lot. But then I ask myself, is this like I wonder, what does a neurotypical do with determination? They don't have it relentlessly. They don't like lose themselves in it. It doesn't have that immersive or that pulling feeling into it.
Our neurotypical friends, and they do make up 90% of the population, for them being interested, challenged, having a reward or something like that is all very helpful, but it's not required the way it is for people with ADHD. People who are neurotypical use two things, and only two things, to help them choose what they're going to do, get engaged, access to their abilities, and get it done. And the big one is it's important.
Yeah.
And that gives them a lot of advantages. They can prioritize. They can arrange things in order of importance. It doesn't have to be important for them. It can be important to the boss, the teacher, the spouse, to their future. How am I going to, have a career? It doesn't have to be important right now. The other one is there's a reward for doing the task or a consequence if you don't do the task.
Yeah. So
I ask people, again, we've been asking the wrong questions. Look back over your entire life. Can you remember even one, just one, episode in your life in which the importance of the task all by itself has ever actually helped you? Or has it just been a nag? Did it help you get started? Did it help you get access to your abilities? Forget that. All it was a nag until you could find one of your 5 ways to get engaged and get access to your tremendous abilities. So that is really one of the things that people are led to believe is that if they just wait long enough, they're going to be neurotypical. Doesn't happen.
So
you don't change your genetics at 18. You don't get this beautiful box all wrapped in ribbons and you open it up and say, just what I always wanted, a new genetic code. Now, that just doesn't happen. We are what our genetics make us. And we have to make the best of what our genetics make us. And the thing is, there's a lot of good that comes along with ADHD. Now, I'm not one of these people that it's, a gift, a superpower and all that and stuff. Being ADHD is hard. It is tough. It's twice as hard as being neurotypical because you have to learn your own nervous system with nobody's help. and you have to learn how to live in a neurotypical world. So you have to learn two nervous systems. One's hard enough. So ADHD is hard. It's not for sissies. But we're finally figuring out why all the stuff that we tried before failed so miserably. So, again, probably a lot more than people wanted to hear about. So,
Not at all.
that
That
was
was so
amazing.
wonderful. And I'm so touched with all your clinical expertise and all of the people that you've seen with ADHD, how when you talk about us and the things that we do and your affinity for us comes through. And I just want to thank you for all the work that you do on our behalf and for being here tonight. This was wonderful. And Beth,
certainly my pleasure. I enjoy it.
well, we appreciate it so much. And Beth, your vulnerability in talking about your own experiences with this really challenging subject is so appreciated, because if we don't share our stories about what these things are like for us, then, you know, it's hard for other people to understand. And when you share, and I saw so many heads nodding, oh yes, I've gone through this, or I feel that too. Like, that feeling of being less alone is why we're all here tonight and why we're all a part of CHAD. And so it just means so much. I'm so grateful to both of you for being here tonight.
Oh,
Thank you.
Suzanne. This has been, I've learned a lot too tonight, so I appreciate it.
It's wonderful. Thank you guys so much. And I want to thank everybody who joined us tonight for being here. You're all invited. I put the link to our Sunday night group. We have an adult group on Sunday nights. We also have a bunch of other groups, so check us out on Meetup. If you go on Meetup, you'll be able to contact me. And if you have any questions about CHAD or ADHD or finding resources locally, please do reach out, because that's what we're here for, is to help you. I see a lot of questions. People are asking about the slides. This beautiful presentation is a preview of what Dr. Dodson and Beth are working on for our annual conference in November. So although they will be available, they will not be available until after that presentation. So just want to let you guys know, be patient. Everybody who RSVP'd will get a copy of the video, but not until after the presentation is over. So thank you guys all so much for being here, and have a wonderful evening. Thank you.